Welcome to Heart Failure Unfiltered. My name is Nick Hartshorn-Evans and I'm the founder and CEO of the Pumping Marvellous Foundation, the UK's heart failure charity. Today, we will be discussing Beyond Diagnosis, how beat heart health events deliver value for the NHS. This is the second episode of a series of 2 podcasts about heart failure and why the simplest ideas often save the most lives. Today, we're looking beyond the individual patient story because while every diagnosis matters, the real question for healthcare systems is, how do we find people earlier at scale? How do we reduce inequalities? How do we bring healthcare into communities? And how do we prevent avoidable admissions before they happen? That's exactly what we'll be discussing today. So this podcast asks one question over and over again. Beyond the diagnosis, why BEAT stimulates being first across the line to detect heart failure matters. It really matters. Because if we don't change how we work in detecting the symptoms, diagnosing and managing heart failure, patients are the real losers.
Why do I feel exhausted even when I haven't done much?
Fatigue is one of the most common symptoms of heart failure. Your heart has to work harder to supply your body with oxygen and energy. Treatment, pacing your activities, and listening to your body can help. Welcome to Heart Failure Unfiltered. Today, yes, we are at the Liverpool Podcast Studios and we're going to be talking about heart failure, if you hadn't guessed. So I'd just like to introduce some of my guests. Gail, start with you.
I'm Gail. I'm a long-term conditions delivery manager and CVD Prevention Commissioner at the ICB in Cheshire and Merseyside.
Okay, Amy.
Hi, I'm Amy. I work for a company called Medtronic. It's a life sciences company. We make medical devices that are used in hospitals and the community in a variation of different types of therapies.
Okay, Gav.
I'm Gavin Redhead. I'm a patient educator with the Pumping Marvellous Foundation, and I've lived with heart failure since 2019.
Great. Okay, so we'll have a good stimulating conversation. So the big question is what are the biggest cardiovascular challenges in the NHS today? Gail.
I knew you was going to come straight to me for that. Scale, ageing population, multimorbidity.
Scale, what do you mean?
Scale is huge. It's huge.
Right.
It's one of the biggest killers. One of the biggest avoidable admissions. So that means when someone goes to hospital when they didn't really need to, most of the people have got some sort of cardiovascular issue.
Do you find it then?
Yeah, usually, yeah.
So it's on a crisis point.
Yeah, they didn't know. Oh, chest pain. I've got terrible chest pain. Oh, yeah, you're having a heart attack. Oh, did you know you had hypertension? Oh, no, I didn't know that. Did you know your arteries were blocked? Oh, no, I didn't know that. Yeah.
So how do we overcome those challenges? Well, I mean, just top of your head at the moment without going deep dive into it.
Prevention, earlier diagnosis.
Right.
Doing things sooner.
Right. But haven't we been doing that for years? Haven't we been trillions of dollars, euros and pounds have been put into prevention and we're in a crisis. 20 years after. So the last time I think when somebody go, no, that's not the case. The NHS really got behind sort of heart stuff. Yeah, was the primary PCI, wasn't it?
Mm.
And one person said to me in front of lots of other people, and I can't believe he said it, but he said, basically, we haven't looked at cardiovascular since the big economic crash in, when was it, 2007, 2008. I'm like, oh, okay, that's why maybe we've got problems. So, Amy, what do you see from an outside point of view? What are the biggest challenges that the NHS has got in terms of its cardiovascular challenges?
Yeah, so when you're talking about the big teaching hospitals, you've got a range of care that's going on in that hospital, and cardiovascular is always top of the board's mind as well. So I work from all different stakeholders in hospitals, and they're often thinking about what are the impacts that are happening in their hospitals, what are causing the challenges, what's causing the blockages. And a lot of the time, it's what's causing those blockages from A&E, so into the hospital, that then stops things like elective care. So that's their day-to-day routine, things that are booked. That causes issues then on waiting lists. And then it also causes issues on resource. So I think what we see is this efficiency problem, essentially, in the NHS, which sounds like it could just be fixed with a magic wand. But there is a lot of different moving pieces in that space. And by doing, great projects that happen around transformation in different pieces of care with the hospitals, we see there is often unintended consequences on different services, or they're not informed. So communication hasn't happened, that they're making changes here, and actually they may see a different type of patient now, or those patients might have a different outcome. And so I think that communication piece has always been somewhat down to the lack of joined up thinking around just not having digital, information about patients. But I think ultimately it's about having good data as well, making evidence-based decisions based on your patient population. And some of the thinking around moving to ICBs was to have a bigger population. You could then take some of the best practices and then apply that to where your biggest pressures were for that region. And that has happened in pockets, but it's not sustained. And that's the biggest challenge, is how do you sustain those good pieces of practice and then scale it so that it actually has a bigger impact? And then how do you take that to its next iteration? So that's where we see it. But having good data and understanding where the blockages are for patients to get potentially devices.
But what rings true for me, Gav, here, sitting here as a layperson potential. Well, I hate the word. God, layperson is such an awful God.
What does it mean?
Person, listening to a conversation that I don't get involved in terms of actually physically. I may commentate on it, but is what happens in the hospital, so in the box.
Yeah.
And how do they manage what comes into A&E knocking on the door?
Yeah.
So where should we be putting our focus?
Yeah, it's got to be early intervention. It's got to be preventative. It's got to be stopping that thing, because
in the community,
it's so much crisis intervention, isn't there? I mean, I lived with severe heart failure for those years, and before I had my transplant, and there's 1 million people plus that we know are living with heart failure. But the routes into heart failure are so broad, aren't they?
Yeah.
But most of the time, it's a crisis intervention at A&E that triggers your access into getting that treatment. If we can go downstream or upstream, whatever it is, I don't know which direction it is, but catch people earlier and stop them ending up in A&E and sort of preventing that crisis occurring in the first place, then surely that's got to be better. It's got to be better for patient outcomes. I know it would have made a massive difference to many of the people that we see in our private forum that are talking about so many of the new people every week that enter into the private forum say, I was in hospital, this occurred, I've just been diagnosed, I had this.
You can predict it, can't you?
Yeah, you can just see it happening time and time
usually
again.
The inhaler comes into it as well.
Yeah, and the inhaler. And I see it more from a female perspective. There's so much misdiagnosis in a female perspective. I don't know about the complexities of that. I don't aim to try and explain that. But seems to be more issues if you're a female that is living with heart failure and hasn't had your diagnosis yet. It seems to be much more of a delay in that scenario.
I think the problem mostly for the NHS is that it was always designed, thanks to Bevan all that time ago, to be reactive, which is what we want. If you had a car accident, you need to go to hospital, you want to be treated. That's exactly what we'd want. It was never designed to do that proactive stuff. And if you think about how it is at the minute, we have secondary care, primary care. So secondary care is very reactive. Primary care is somewhat reactive. I feel ill, I need to go and see a doctor. And then we have that prevention piece. And I think everyone is a little bit like, well, whose responsibility is that prevention piece? Well, we could argue it's everybody's responsibility. But if we think about the NHS like a building on fire, so our hospital is on fire and we're trying to put the fire out, and that's the patients coming in. And actually, Gavin over there wants to talk to us about when we buy our new house, what fire protection are we going to have? Well, we can't think about that right now because we're still trying to put the fire out. And until we get to the point where we can deal with the fire prevention stuff whilst we're putting out the fire, that's exactly what's happening for our patients. We need to start thinking about that prevention stuff, but that's really difficult when we're dealing with all the reactive. I think that's happening.
The other challenge that comes is obviously you've got cycles of government, and and government are trying to put headlines. We're in a very immediate world where people are grabbing at headlines, and prevention doesn't produce data straight away.
10 years
and that accountability piece gets lost with all the changes. That's the challenge then of measuring the impact of prevention and sustaining it, because it's a no-brainer, but you can't measure it in the cycles that we need to measure it in. Yeah.
So how much of it is out there, Gail? how much preventable CVD, and that's like, that's blood pressure through to heart failure, with everything in between, heart attacks and AF and atrial fibrillation, which is a rhythm issue, and type 2 diabetes. And how much is out there?
I would say there's a lot, and I would say the majority of it is preventable. When we're seeing people with heart failure, we often say things like, well, the ship has really sailed for them. But that's because lots of other things will have happened to them beforehand. They might have got hypertension, they might have gotten diabetes, they might have kidney failure. Lots of things that have attributed to them having the heart failure. They didn't just wake up one morning and be like, oh, I'm having heart failure. So lots of things could have happened to them before then that would have prevented them getting to that stage, And it can be as simple as somebody saying, oh, Gav, have you had your blood pressure checked? Or you're feeling a bit breathless, have you seen somebody? There's really simple things that we can do. But it's a chain of events that leads you to that point. It's not just, you don't just wake up one day and your heart's suddenly failing.
Are we using the right word though? Preventable?
Primordial.
That sounds like something dinosaur based,
isn't it? Yeah. But that's before the things happen to you. So our children that are born into society now, it's inevitable they're going to have hypertension. They're going to have all these things because the lifestyles that they live. That's just how it is. We eat a bad diet. We don't exercise. We eat too much salt.
Is it all preventable though?
I'd like to think so.
Okay. Isn't there be careful where we go with this, but isn't there genetic propensity for sort of
so
stuff?
We could diagose children and say,
should we be using like
predisposed,
manageable? It's becoming a bit, we instead of the life and it goes downhill and it's like that. Could we just do that with it?
Yeah,
it's risk mitigation, isn't it?
Yeah.
Right, health risk mitigation.
So therefore, is prevention the right? I don't know. I mean, I've just thought of that.
I suppose it is. We're preventing somebody going to hospital, we're preventing them from being ill. Depends what we're preventing them from doing. What we really want is to prevent them from becoming ill. But at the minute, what we're doing is preventing someone dying when they are already ill.
So how does the Beat Heart Health events, how do they support the current way of thinking, the neighbourhood model, doing in the community? How does it support it?
So that's part of our NHS 10-year plan, and one of the elements of that is bringing care closer to community. So taking it from hospital into the community.
Is it just a soundbite though?
I'd like to think not, because what you find is patients get better outcomes if they're looked after in their communities than if they go to hospital. It's kind of like once you've gone to hospital, it's a little bit too late. And actually, if we bring it to the community, things are likely to happen much earlier. So if you're in the ophthalmologist having your eyes tested and he asks you about your blood pressure, you're much more likely to be diagnosed with hypertension then, rather than turning up in A&E because you've got chest pain. There's things that can be done earlier, but that happens better in those communities. People have more trust in their own communities. People are just doing things in their own community. They're not going out of their way to have to go to hospital. They were just there anyway. So why aren't we testing them for things that could be killing them?
But Gav, does it just feel like a load of sound bites?
Well, I mean, the neighbourhood model, I worked in local authority and the neighbourhood model was there, but it was kind of more linked to community sort of policing and that side of things. It was bringing those people together, but they also brought health services in alongside that. So why were people reacting or doing what they were doing? Why were they drug taking? Why were they doing? What were the opportunities to capture some of those health issues and try and prevent some of that and try and move people away from criminality and get them back onto a healthy lifestyle? So the neighbourhood model, I can see it working really well, but you've got to fund it and you've got to make sure that that happens. And as well as bringing that together from a system, whether that's the health side or the supporting organisations, or whether that's a general public awareness raising as well. So there's two sides to it, isn't there? If you don't know what heart failure is, and I could walk out of that door and ask the next 10 people I saw, and I don't think I'd be lucky if I got one of them to give me a definition of heart failure. If you don't know what heart failure is, how can you self-refer in? You're reliant on people screening you into the system or ruling you out, as you've said before. There's a need for more public awareness to attend some of these events and come along and get screened, and as well as just some of the preventable side as well.
Yeah. I suppose it's difficult as well. We can make the public aware of these things, but for some people, it's not a priority. Health isn't always a priority. Yeah. If you've got to decide this week between whether you're feeding the kids or putting the heating on, not in this weather, putting the heating on, that's like really bad for your mental health. And so you're not thinking about the fact that you haven't taken your diabetes medication because you haven't had time to go and pick it up from the pharmacy. You've got other priorities, and sometimes that's kind of the thing for people, isn't it? That the health is not their priority. It's all the other things that are happening to them in their lives, or actually they don't know how to make those good life choices because they can't afford it or because they don't know how to do it. You know, someone might not know how to prepare a Swede, but they do know how to go to the chip shop and buy chips for all the kids. And actually that'll feed all the kids for a few pounds. Whereas to go and get a Swede and cook it and boil it and, and get some meat to go with that, it's a lot. And I think for someone who's got a lot on their plate already.
Mashed Swede with pepper.
Really?
But I think that's a lot for someone to think about. I'd love to just think about mashed Swede with pepper. I work in the NHS, so I can't only think about that. I've got a lot to think about. But people with poor lifestyles, they're thinking about all those things as well. You're thinking about when's the next meal coming? Where am I getting some money for the electricity meter from? You know, when the loan shark comes, what am I going to say? Because he's going to take the sofa away because we haven't paid the bill this month. They've got a lot going on, so health is just not their priority.
So what type of people, what populations have we reached with Beat, do you think?
Some of the most hardest to reach. We don't like to call them the hardest to reach, least likely to engage. And they're the reasons why they've got other stuff on their plates that means. Why do
you shy away from the hardest to reach?
Because it's not hard to reach. They're just busy doing other things. They probably do want to.
So they're not the traditional, sort of what we'd say in high deprivation index areas where. So you're saying basically it's not on people's priority list. It's not on their agenda.
Yeah,
and they're the hard to reach people.
Yeah. And in some ways, why should it be? You know, I would absolutely want a mum to choose her kids over going getting her diabetes medication. But what we need to do with the neighbourhood model is say, okay, how do we help you with all the debt and things that you've got going on so that then we can talk to you about getting your medication and doing a bit of exercise for yourself.
It's time for a marvellous myth buster, busting the myths around heart failure. Myth: taking heart medication means your heart is failing.
Truth: heart failure medications help protect the heart, improve symptoms, and can help people live longer and better. There's a conversation about trust.
Yeah.
And trust is, trust makes the world go round, basically. Some may disagree, but I think trust is really, really important. And how important is trust when we're starting to shift healthcare into communities?
Really important.
We had a conversation about Everton in the community. I remember the podcast that we did. It was not just these podcasts, there's Everton in the community podcast, where we had that conversation. And Amy from Everton was talking, and both of you were singing on the same hymn sheet. It was like a concerto, yeah? Exactly the same, slightly different language, but moving stuff into the community is very important. So why is trust important?
It's important because we're talking about things that people are worried about. People are worried about their health. If they're coming forward to say, I'm not well, they're worried about it. They're concerned. They might even be concerned about their families, their pets. You know, someone might say to you, I can't go into hospital for that because who's going to look after my dog, or who's bringing me my shopping on a Wednesday? You know, they've got that kind of stuff going on. And so what we need to do is to gain their trust. But when we think about communities that don't usually engage with us, maybe communities that don't speak English as a first language, we might have to approach the imams or the pastor at the church to say, they trust you. We need you to give this message about go and get your heart checked for heart failure, because they trust that person. They're not going to trust me, a middle-class white woman coming in saying you need to get your heart checked. They're going to be like, what do you know? But they will trust people from their local community. And that's why we need to do things there, because they'll look at that then. Those people in my community think this is a good idea, therefore it is a good idea and I need to do it. Whereas if our white doctors from the hospital or any doctor from the hospital comes out and says to somebody in a BME community, you need to do this, they don't want to listen, or they kind of have that view, you don't understand, you don't understand the type of food that we eat. You don't understand the type of culture that we have, which is probably true, we don't, but the communities that they're in do, and that they can give those messages for us. And that means that there's trust there because it's someone from within their community saying, this is a great idea and I really think you should do it. And actually, if you do it and you are unwell, we're all here to look after you.
But as an expert in what you do, and you are, your definition of hard to reach is very interesting.
Do you think?
Because I haven't thought about it like that, that actually it's about whether it's on somebody's agenda or not. And I'm going to give you an example.
Yeah.
So we know in Sefton, not far from here, that Sefton is a very diverse community. So at the north, you've got a very wealthy community in Formby and sort of Crosby, Blundell Sands area. And then you've got high deprivation in Bootle, which is the south and in between that. And I think it's just as difficult to reach the affluent communities. And they've got a lot of long-term conditions, You disagree with me there?
I disagree a little.
Okay,
in that they have access probably better than our more deprived communities. So you could text somebody in some of those affluent places and say, fill in.
But I'm talking about the emotions of making that decision of whether I go to a beat heart health event. If we did it in Formby, or if we did it in Blundell Sands or no, probably have to be in Formby because nobody from Formby would come. But did it in Formby, and we did it in the Strand in Bootle. And I know this thing because I'm a Scouser. I know, and I went to Hubert College as well. So it's about putting it on people's priority list, isn't it?
Yeah.
It's not the sort of, I would say, communities where there's challenging to reach. It's not about that.
I suppose it's probably about their outcomes. So we might say that middle-aged men are more difficult to reach because they won't go to their GP. They're likely to have better outcomes than a South Asian woman. We just know that they have poorer outcomes because they don't access the services, they don't read it in their own language, they don't read the information leaflets that you get given. There's lots of things that they don't do.
Also they struggle on with it for a long time as well.
Yeah.
Therefore present late.
They don't want to be a burden a lot of the time. They feel that they keep this to myself because, I've got things to do. I've got my husband to look after, my kids to look after, and the shopping to do, and we need to go to the mosque. And we've got lots of things to do. Actually, they don't have time to just say, well, actually, I'm not feeling so well. It's when they're at crisis point, suddenly they can't look after the husband and the children and go to the mosque. Now I'm at crisis.
So how do we put it on somebody's agenda, everybody's agenda? That's a big challenge, yeah?
That's a big challenge, yeah.
So here we go. Here's a potential solution. Amy, how do we improve collaboration between charities, government-funded organisations like the NHS and local councils and other government quangos, and life science companies? How do we do that?
So we're in a unique position in the first time ever from a policy perspective that is driving the way that we all behave with the NHS social value model. So that has laid out quite extensively what being a good or ethical organisation is when you're operating in England, essentially. And I feel really proud of the team at Medtronic that we've already been doing this and that we've allowed that to, we've used this as an example of we've already been doing this. We've been talking about how we add value more than the device. We can't just talk about the price of the device, but we are doing all of this other stuff because we believe it's the right thing to do. We now have a mechanism to do that, but it also provides a unique opportunity for all of us to collaborate in a different way because it provides the framework to build on the antitrust piece. So that makes it really hard for us to collaborate in a legal way where it's, there's no bribery, and we build that trust across the organisations. But it also might drive us as industry to work collaboratively within industry. But I think there's also something there with the other patient groups. How do we access that between charities as well to access those communities? Because they'll have a lot of knowledge about how we get to those communities and where and what are the root causes behind some of the behaviour or some of the issues that they have, and how do we support those neighbourhood models? I think when it comes to, and I think it's still it's being ironed out as to what good looks like, we can use the NHS social value model as well to go to different stakeholders about what good looks like. So we were talking about before of it's our responsibility to bring these things to the forefront and show that it works, show what the impacts are. And it provides us a different group of stakeholders to go and do that. So some of the team in the sustainability team, for example, have gone, wow, that's incredible from a prevention perspective. Like, how does that tie into other programs? And so that's an early conversation, but it just opens different doors. And it means that inside the NHS, they're also hearing it from different people. So I think there is going to be a growing number of these types of initiatives. It's about making sure that we're not just ticking a box and building on something that can have a sustained impact. And that's going to be some of the challenge between like industry and working in these big collaboratives.
So would you be right in saying that collaboration accelerates innovation?
Absolutely.
Or change?
Yeah, absolutely. Because you solve the problem with different perspectives in the room. So you iron out a lot of the unintended consequence. And as long as you've always got the patient at the centre, you can apply that system level thinking with experts in the room rather than trying to make siloed change, which ultimately will only benefit a part of the system. So I think collaboration is absolutely key.
What have you observed from the Beat Heart Health events that we could take into other areas? What do you think?
Well, I think that the model, it applies to probably all cardiovascular, if not all illnesses. You know, the way that we do it, bringing it from the hospital to the community, that model is something that you could use for everything. It doesn't have to just be heart failure. It works really well for heart failure. I think it would work for a lot of other things that go undiagnosed. Hypertension would be one of them, type 2 diabetes. You know, just doing that screening test to say, is there a chance you could have this in the community? Yeah. Well, we can care for you in the community. You don't have to go to the hospital. Patients love that. We have some diabetes clinics that happen in the community. They're provided by a consultant from the hospital, but they happen in GP practices. But when you ask the patient, well, did you go to that consultant clinic that's provided by the hospital? They'd be like, no, went to see my GP practice. Well, that was the clinic. Oh, no, I thought that was my G. So they think that that's something that's happening in their community. And that's where that trust is again. You know, they trust the service because it's happening within their GP practice or it happens at their local community centre. They're not having to go to hospital for it, which is brilliant because then they've not had to park in the car park that's cost them an absolute fortune. And they've not had to get Doris down the road to give them a lift there. And, you know, there's loads of good benefits to be had from doing it in our communities.
So you're going to pull all this together, aren't you, Amy?
Yes.
Can't tell people too much about it, but what does success look like from a Medtronic position?
I think demonstrating that trust can be built and that collaboration is very viable, right?
Yeah.
And that there is benefit to everyone in the system by doing that collaboration, even if that's, you know, through project management or expertise on the day or just...
Well, look what they've achieved working together.
Literally making sure everybody's in the queue is okay, right? Everybody plays an integral role. It's just like sports teams. And you have to have every type of role on that pitch in order to make it happen and all surrounding. Yeah. And I think from a Medtronic perspective, you know, we make devices, but we're in the business of healthcare. We have no other arms to our business like some other organizations. And so we have to be part of making sure that the health service exists, essentially, but for the right reasons, right? We've got plenty of other crises coming our way. Climate crisis is going to have a compounding effect on cardiovascular disease. We've got aging population. And so ultimately, you know, those two economic crises, all of this coming has a compounding effect on the number of patients that are going to need services from healthcare. But I think, which is sad, really, when you think about it. But I think we have an important role to play, not just to treat a patient, but also to understand the pathway that they're in and the disease profile. So
Gav, we talk about, well, what does the word transformation mean to you in context of healthcare?
I mean, for me, it is really about that upstream, or I said before, that preventative side of things. I think it's about thinking about where you access people. And while you were talking, it was interesting. I was thinking about to when I used to work with young carers. So you've got young people that are acting as the main person that's controlling the household because of disability, ill health, or whatever. And I was thinking about your issues about communication, translation. Who does a lot of that? Well, it's young people that do a lot of that, a lot of teenagers. We're looking at neighbourhood buildings. Well, we've got schools, secondary schools that have 1,000 pupils in, 1,000+ pupils in. Well, if we could do some kind of event in a school setting and use young people as the mechanism to draw people in, parents, grandparents, bring them in. It's a familiar setting. It's a setting that has lots of resources, rooms, facilities. Yeah. Great setting to do things. If we could bring that element in schools. I'm not sure whether it's been thought about, but actually bringing schools as part of the neighbourhood, they have more contacts, day-to-day contact with parents.
Yeah. I think that's the important thing, isn't it? What makes up a neighbourhood, and whoever you ask will tell you something different. But I think it's those things that make up a person's life. So education is one, your health, your fire, your education, family, housing, shopping. You know, all those things make up a neighbourhood. Something that person does, and the hospital probably is part of that. But it's kind of outside, isn't it? It's kind of over there on its own, and actually not in the neighbourhood. But actually, what we could do is bring a little bit of that.
Does it feel a bit superior to their neighbourhood?
No, I think it's just different. I think it's got a reason to be over there on its own, because you should only need to go over there when you need to go over there. Everything else should happen.
But is that a bit permission based then?
No, I think anyone could probably go over there, but actually you don't really want to go over. You don't want to find yourself over there.
Is that why we get late presentation?
Yeah. It's a bit scary to go into hospital because most people know someone who went in and did not come out.
Yeah.
So it's like, I don't want to go there because I know what happens to people that go
One of
there.
my rallies keeps telling me about that.
Yeah.
Yeah, you go in, you don't come out.
But that's not something that's just for people that have had a relative die. And I remember when I was a child, I was at a nursery, and I remember, my mum tells me, people used to go upstairs, and I'd be like, I don't want to go upstairs. And she'd be like, why? I'd be like, people don't come back from up there. Well, people were going, people were going from like preschool to nursery. People obviously then went home at the end of the day. But for me, that's all I saw was people went upstairs and just didn't come back.
Do you think that's a big problem that we have?
In nurseries, no.
Yeah,
I think the way people view secondary care, I think, can be problematic. Generally, it's where you go, you're in heart failure, you've had a heart attack, somebody's got cancer, somebody's been run out. Horrible things happen when you go to secondary care. And so why wouldn't we associate that with badness? And we do. And it serves a purpose. That's the place you go to get that special treatment. Actually, what we need is something in the community is where you go, I think I might have this. Okay, let's see you. Oh, actually, yeah, there's something we can do about that. Do we need to go to hospital? No.
So in terms of prevention, are we talking the wrong language to the population then?
But we usually do, don't we? We usually do speak the wrong language to the population. We use all this big terminology, and we could say it a lot simpler.
Yeah, that's why I was sort of asking about terminology and things like that. I mean, impact on people.
Yeah, we've used a lot of acronyms today, and I think we'd have to have, almost like
another glossary.
There's other things. But I mean, even this morning, I received a BMI questionnaire from my thing. Yeah, I don't know why I get it, but it's like, can you put it in? Because they haven't got the latest data on there. But a lot of older people, I'm not saying all the people because I'll get accused of bigotry and things, but there's lots of people that won't be able to do that, and the only time they'll get that information is the next time they present at the health departments, etc. But there's so much software and technology that's coming into that, and the virtual ward, I mean, I think that's phenomenal. Heart failure at home and those kind of programs, I think that's a phenomenal thing. I was on, while I had a heart failure, I was being monitored at home. I put in, I used a phone, I put in information, and people used to ring me up if it spiked for any reason. And I think a lot of that is coming, and I think a lot of that needs to come. Yeah. And we move it more away from that primary care element and move it back.
Yeah.
So do you think more people would engage freely with healthcare services if you moved into the community then?
Yeah. I think that's, for me, that's the thing. It's a familiar setting, a more comfortable setting, people that I'm more familiar with. And I can have that conversation with my next door neighbour or somebody I know from the bowls club, etc. That's a more comfortable area for me to access it rather than going and getting that blunt diagnosis or that blunt piece of information in a setting that I don't want to go to.
So how do we measure success? So what should we be measuring from the BEAT program? And is success simply about numbers because we're obsessed with increased data? Bigger numbers change things, and people listen when it's 10,000, not on 100. Should we be looking at earlier diagnosis, reduced emergency admissions, faster access to treatment, flattening health inequalities, improving patient activation? Mm-hmm. So how can programs like BEAT support the future direction of where we're trying to go?
I'd like to see it be sort of at the forefront of how we make community events like what we do embedded into community. So it's community detection, not a one-off event. Like you said, I'd like to have one every week, but actually that's right. Why doesn't that just happen in the community? Why is it not just there? So you pop in to see, I don't know, the debt advice counsellor, and while you're there, they just
happen. You said the death advance, the debt advice counsellor,
the debt advice counsellor. Say, for example, you go in to see them, and they say, "Sure, do you want to? We're doing a heart screening test today. Would you like? Oh yeah, go on then. Oh, your early stage of heart failure. We'll do something about that. We just make that a bit more the norm. And at the minute, it's like, let's have a big event. We'll text 40,000 people and hope 300 come. And let's not have it like that anymore. Let's just have it as part of that's what we do in the community, and that's where this happens. And I think we are getting to that, but I think this is the tip of the iceberg.
I mean, we could really teach the world to sing in perfect harmony. Yeah.
You're going to sing again?
In terms of, show me age, I think. But in terms of here you go. If we invested in 3 postcodes in your area in Liverpool, and we did what we're talking about, which is about embedding choice
Yep.
in terms of heart health screening or screening of whatever.
Yep.
And it was just the norm that if somebody didn't turn up on a week, or so we didn't see anybody, and there's just you sat there waiting, twiddling your thing. But actually next week it was 100 people.
Yeah.
So it was very much up to the people to engage. Do you think we'd reduce anxiety for people? Because I see it all the time in these Beat Heart Health. I see the anxiety, the mental health challenges around, have I got a condition that's going to kill me?
Yeah.
Do you think in those 3 postcodes, do you think we could flatten that and take attitudes differently?
Yeah.
Or change people?
Yeah. I think we have done that with other stuff. You know,
I was about to say, yeah, wasn't usually you. Usually give a bit more.
Give it more. Yeah, we have done that with other stuff, but I think pick a postcode. I think it's going to be tricky, isn't it? It's going to be very different depending on what postcode.
But let's just pick a postcode, yeah? Let's say we cut Liverpool in a quarter.
Yeah.
In quarters, yeah?
Yeah.
So we take South Liverpool.
Yeah.
Yeah, and we do what we're talking about.
Yeah.
Do you think it would change things?
I hope so.
And do you think we could influence the rest of the NHS to scale it?
If we love numbers, don't we? So if we look at that tiny little version that we did in South Liverpool in Speak, we did a small number of people and we probably made a difference in their lives, and amplify that to whatever size you want, then that's going to make an incredible difference, isn't it? Even if we save one person, to me, then our job has been done. But actually, if we could save 100 people, well, why wouldn't we do that? If we could save 1 million people, why aren't we doing that? That's what we should be doing, but we need to make it just routine. So it's not a special event. It's not somebody just sitting there waiting for somebody to come along. It's just part of what we do every day. There's just people being seen whilst you're waiting in your GP surgery to see the GP for something else. You get a little, let's ask them about their alcohol. Let's ask them about what debt they're in. Let's ask them if they've got any mental health problems. Are they struggling with anything? Let's just ask somebody, how are you doing today? Let's just make it part of what we do in that neighbourhood and save that hospital trip for when you really need it.
And that's transformation. Yeah. That's not like changing the deck chairs, is it?
No.
This is like system change. This is attitude change. This is impacting the emotion of why people make decisions. So it's not a data-driven thing. Actually, we use the data to support the emotional need.
Yeah.
Wow.
Yeah.
Maybe we should go and try and get some lottery funding to do that. I think we need more than the lottery, actually.
We like to call that population health.
Yeah.
And so what we do there is we take a data lens and we take a person lens and we put the two together. So it's kind of like a top down and a bottom up approach. And, Amy will tell you the system's really complex, but the one thing that's really simple is that we take what we know. So we know lots of people have cardiovascular disease. And then we look at the population and say, where is that cardiovascular? Well, it's in this particular postcode and it's in this type of person. So then we focus on those specific people. It doesn't mean we don't look at everyone else. It just means we add a bit more for just those people.
So looking 5 years ahead from your position, Gav, where are we? Where are we in 5 years? Not where we want to be, but where are we?
Yeah. Well, there's 2 sides for me. We move to this neighbourhood model. We get people coming through the doors, getting screened, that the services have been rearranged or made aware that that's what needs to happen, that we start to do that and we screen it. And then there's a second awareness about wherever we do it, we promote actively the BEAT model to make sure that people are aware and why they need to come into that service or that system or that opportunity.
Yeah. We have, obviously, you have everything in the community, which is where we have one of the BEAT hubs. But what that provides there is something that captures people's attention. So you might go along there to have your BEAT check, or you might go there because you've got a long-term condition to do a diabetes program there that lasts for 9 weeks. And so you go in and you see people and they'll be like, well, what's happening over there? Why is that woman lifting weights? It's like, well, that's the exercise class that we have on. It starts just after this. Do you want to give it a try? Oh, no. Well, do you want me to come with you and we'll do it together? Well, yeah, go on then, I'll give it a try. And then next week, there's Mavis. She's in the exercise class doing pumping iron. And then you say to her, well, do you enjoy it? She's like, yeah, and after this, I'm going to that. And on Friday, I'm coming to this club and I come to the food bar. And suddenly that's
do you know what? My friends come as well.
Mm-hmm.
Yeah.
Yeah, and I've made some new friends as well.
Yeah, and they tell people, but they keep going back because it's a place to go where they trust
infectious.
People and they know.
Yeah.
But what they don't realise is actually we're weighing them and we're measuring them and we're checking them and we're giving them advice about the health and we're making sure they're taking the tablets. But actually what Mavis will tell you is I come to the gym. I don't get any of that other stuff. I just come to the gym.
Interesting. So, Amy, what role does community-based cardiovascular detection programs like the Beat Heart Health events, what role does that have in transforming how heart health outcomes appear across the UK in the future? Where are we in 5 years? Have people listened, or are we just arguing between ourselves? Somebody said to me today, all right? Somebody said to me today, I was on, when I was driving here, I had a good long chat, and he said, what's happening currently potentially is going to put us back 20 years. So, but I'm asking the question, where are we going to be in 5 years?
Yeah.
What does that feel like? Feel like from your perspective as a, oh God, I hate this phrase, service user. from a person perspective, where do you think we're going to be in 5 years?
That's a big question. I think we are going to see a lot of change come. Are we going to be able to move as fast as some of the changes could help us? So, for example, AI is the big buzzword and could be used. We've had AI in our devices for 10 years, right? Mm-hmm. But from a big...
People don't realise that though, do they?
No. So,
they think it's all about generative AI and,
and it's
Claude
brand new.
and ChatGPT.
But it has some amazing uses and it really helps enable some of these models. It will also help when we've got some of that data joined up to help with some of that predictive aspect of, well, actually you were breathless, and it might prompt people in the system where they see you. I think people will become a bit more, as a person, will become more intrigued about their health when they know it's not always going to be bad news in that space as well, because I think people will become curious about what data could tell them about their lives. And I think that's an opportunity in itself to reduce that anxiety, but also have different conversations with people and get them into that screening and say, well, actually, if we do this screening, then actually you'd be ruled out. Yeah. But also, I think that curiosity exists, but it will help us communicate differently with different communities as well. I think in 5 years' time, I would love to see prevention be just a business as usual model that is funded correctly.
We just do.
Yeah, business as usual.
Business as usual.
This is the muscle memory.
It's not a new project. It's not, we're not in pilotitis. It's just part of what we do. We've understood our population, and actually this is what we need to do. And it's not so cyclical. And we can measure some of those outcomes on not just heart failure,
do we need
but
to take
diabetes.
it out of the political system?
Or
does it just become another political system?
I think it just always, I think that's where the right decision makers at the right time, the challenges we have a changing system because of our political cycles, right? So we need to find a forum that will allow for that sustained change without those political agendas changing, because sometimes just change of terminology, even if you're doing the same thing again, that change of terminology makes people think it's hard.
So
that behavior change piece, they think, oh, I'm going to have to do something different. You're not. You've just called it something different.
That's interestingly where the ex-health minister, Wes Streeting, talks about communities a lot.
Yes.
And that is definitely embedded in the psyche.
Yeah.
I give him that, that communities are important. But the future of cardiovascular care cannot rely solely on waiting for people to become unwell.
No.
Yeah. And what we've been talking about today through the BTHF heart health events and the whole BTHF program, it must be proactive. It must be preventative and more manageable. Just introduce the word manageable in there. But ultimately, there's a huge benefit in it being closer to communities. Yeah. And on that note, marvellous discussion. Thank you very much for your honesty. Some tough questions there. Great answers. So a lot to chew on. Hopefully, if you're listening to this has opened your eyes or maybe compounded some of the challenges that you have on a day-to-day basis. And if you are somebody with a long-term condition, we're definitely thinking about you. So on that note, thank you very much.
Thank you.
Beat Heart Health events show what becomes possible when patients, healthcare systems, charities, and life science companies work together around a shared goal, finding people earlier, treating them sooner, and helping them live longer, better lives. Because when it comes to heart health, earlier changes everything.